Hello, Kidney Warriors! James here from Dadvice TV, your online kidney health coach, and this is episode number 260 of Dadvice TV, and we're coming to you live. So if you have comments, questions along the way, go ahead. Like Alicia right here. Hey, Alicia, great to see you. Hello back to you. Go ahead and post those. Now, our guest today is the author of one of the best books. Let me make a quick little audio adjustment real quick here. One of the best books for kidney disease patients. And if you haven't seen his book, this is definitely a book you got to check out. It's Learn the Facts About Kidney Disease. In my opinion, this is by far the one book that every single kidney patient should have in their collection. As a matter of fact, I wish every doctor that diagnosed a kidney patient would hand them this book, because every day in my mailbox, I get emails from people, and I was just talking with Dr. Rosansky about this, from people who are just diagnosed. They're stage 3, 3A, 3B, and they're worried. And his book will help take care of those worries by telling you what you really need to focus on, what you need to watch, and what you should be doing if you have kidney disease to help delay or maybe even avoid the need for dialysis. And that's kind of a little bit of what we're going to talk about today. We're going to talk about stage 3A, which is the most populous of the kidney community, what you can do to help live longer, improve your quality of life, manage your kidney disease, and hopefully never ever have to worry about needing dialysis. So let's go ahead. Let me bring my guest, because I've kind of started to give it all away. Let's welcome back the author of Learn the Facts About Kidney Disease. And there's a link right there, go.dadvicetv.com/book, where you can get your own copy of it if you would like, or go to your local bookstore, your local mom and pop. Give them a little bit of love. Amazon gets plenty of love from everybody else out there. Visit your local store and say, hey, can you order me a copy of this book? It's a great price. It's very easy to read, and just goes a long way with helping kidney patients feel more in control of their kidney disease. Please welcome, here is my co-host tonight, Dr. Stephen Rosansky. Hey, Doc.
Hey, James. Good to see you. Good to be with all your viewers. I love being on your show, and I love the questions. And as I told you earlier, we will have time for questions. Before I introduce myself, James likes me to do that. I want to just say something which I hadn't said about the book. I toyed with the title of the book. I was going to say The Truth About Kidney Disease, because there's so much falsehoods out there. There's so many people that are misguided, misdirected, and there's so much stuff on the internet that absolutely has no value for you as a kidney patient, that's being pushed by people with no scientific background and basis. And the stuff in my book is all evidence-based. It's got, not that any of you are going to go through all the references, but it is fully referenced. And tonight we're going to talk about stage 3. And I venture to say that a lot of my colleagues in medicine are not up to date on some of the changes in these stages. And we're going to give you the most recent evidence about stage 3, and especially stage 3A. I am a retired kidney specialist. I took care of kidney patients over 40 years. I still see kidney patients in the free clinic. And I've myself done a lot of research on progression of kidney disease and the issue of when to start your dialysis if someone really needs it, and at what level of kidney function to start. I have over 100 publications in my name. So I've been around, and this book and James' program, I think, is a great opportunity to get to you, the patient. And whenever James is ready, we'll get right into business.
I am ready. Or I'm going to remind everyone, for those that are new, go ahead, post questions in the comments, whether you're on Twitch, YouTube, or Facebook. I see all of them, and I try to ask Dr. Rowe a few of them if they fit in with the points he's talking about or the topic he's talking about. But he always sets time aside at the end and loves to go back and get your questions. So if you ask a question, please provide a little bit, as much information as you feel comfortable with. And I can't give diagnoses here, but it's great if you wanted to know, hey, my doctor mentioned something. is this something I should be worried about, or what are some questions I may want to ask my doctor to learn more about it? He'll be happy to answer those types of questions. Okay, go ahead, Doc. Let's talk about how to live longer, and I want to say live better with CKD stage 3.
Just to kind of address what James just said about your questions, one of the viewers last time asked me a question about the causes of kidney disease, which, if we have time, which I think we will, after I discuss the stage 3 issues, we'll get to the causes. That was one of your questions, and I'm going to address it tonight. So most of you are probably having EGFR numbers in the range, this is a range of 45 to 60. In today's world of staging, that's called 3A, okay? And it's been estimated that half of all the people that have been called CKD, or chronic kidney disease, that scary title, which I dislike a lot, but that's what's out there, are in that category. The first thing to know is that two things, and we've said this a couple times: labs that are up to date with the latest evidence about these stages are not even reporting EGFRs over 60. They're saying they're over 60. Why? Because they're extremely inaccurate and unreliable. So if you're in that over 60 range, not to worry, it probably doesn't necessarily mean a lot, okay? On the other hand, the other really important thing, for those of you who got a number like somewhere between 45 and 60, or even over 60, to see whether that number is real, it needs to be what, James? You paying attention?
Repeated.
Yes, attaboy, James.
Over
I like
time.
it. Over at least 3 months. That's what the experts like myself have gotten together with other experts, kidney experts. We said, hey, these numbers vary a lot. The number is not one number. Your number is not 55.4 or 56. It's plus or minus 10 or 20%. So if it's 60, it could be 66 or 54. Easily could be the same number. So don't get hung up on any one number, either to say, hey, I'm getting better or I'm getting worse. Okay. You need two values over at least 3 months that are below 60. And that's the way we've said we're going to define chronic kidney disease, unless, of course, you have what, James? You could have over 60.
If you have other factors like protein leakage in your urine.
Exactly. If you have protein and or blood, and usually the protein is more important, in the urine, you can be considered to have CKD even with numbers over 60. And that is where stage 1 and 2 come, because stage 1 and 2 are over 60. The other critical thing, and James is a living example of this, is that you can't be called and have a number that you can really rely on as far as your EGFR. All of you probably have that lab value, your EGFR, which is the kidney function number, which E stands for estimated glomerular filtration rate. That's what the kidney does. It filters your blood. If you have something called AKI, which James had, where your number of your EGFR crashes, it could crash for many different reasons. It could be due to low blood pressure. It could be due to medication. It could be due to dehydration. This is not your baseline number. So just because you went into your doctor and your EGFR was 30 or 20 or even 15, because of one of these acute things like low blood pressure or being on a medicine that messed your kidneys up, that's not your baseline. Your baseline is going to be the number that you come back to after your dehydration or whatever the problem has been corrected. Now, it's been estimated, and I might have put this in my book, and I try to stay up to date, and that's what these Dadvice TVs are, keeping you guys fully up to date. It's been estimated that 1 in 10 people have so-called CKD, but that is no longer thought to be the case, and I'm going to tell you why. There's a couple reasons. Number one, I mean, if you just take the number without looking at anything else, maybe 1 in 10 people are going to have an abnormal number. But when you look at the over 60s, not to worry, and you look at the issue of your number needs to be looked at according to what your age is. Because as you get older, it's expected that your EGFR will be lower. So if you are over 70, 3A may not be CKD. In other words, over 70, if your EGFR is 45 to 60, that could be considered normal for a lot of folks over 70, as long as you don't have significant protein in the urine. Okay, that's the proviso. If you got significant protein, then you have kidney disease. And somebody asked, and this has been asked a few times, what is significant protein? And I'm going to get to that tonight.
I was just about to ask you, Doc.
I'm going to get to that tonight for sure.
Just like when you say older folks, don't forget to define that.
Right, exactly. Like I said. So let's say you've got a 45-year-old out there, and that 45-year-old said, well, I have a 60. Is that good? No. If you are 45, you should be at least 75. Okay, so just like if you're older, 45 to 60 may be acceptable. If you're younger, that's probably not going to be acceptable. Let's say you're 45 to 60, then anything less than 60 is probably abnormal. Okay, so if we combine all this, if we combine the fact that one value, if you repeat it, and here's a real interesting thing. 1 out of 3 of you that went to the doctor and found that you had an EGFR, let's say of 45 to 60, when you get it repeated, 1 out of 3 is going to be normal. I can't tell you how many cases I've seen of that. And when these stages first came out, kidney docs were getting overwhelmed with patients, and they didn't need to be seen. And what the kidney docs have decided, and I've been in these international meetings of kidney docs, we decide, well, when should a patient come and see a kidney doc? Guess what, James? What do you think the level of EGFR is that we kidney docs say, time to see one of us? What would you guess? What
I'm
stage?
going to guess, well, definitely in the 30s. So I'm going to guess 45 or under.
We have said stage 4, which is under 30 for sure. Now, again, if you've got protein in the urine, it changes the game, all right? And when you take into account the fact that when you repeat the EGFR, or for that matter, you repeat the urine protein, they will often be normal the next time they're checked. So maybe only, not 1 in 10, but maybe only 1 in 30 people have real CKD. So it's certainly been overdiagnosed, and for that matter, overtreated, because as James will tell you, he's talked to and heard from numerous people with these numbers around 60 that worry that they're going to die, they're going to need dialysis, and so forth. And James will reassure them, and I will reassure you, and my book will reassure you. So let's get right into that question. Who among you with stage 3 are going to need dialysis or a kidney transplant? Now, of course, I don't have a crystal ball, and I can't tell you anything other than general numbers, but roughly 1 out of 100 folks with stage 3 will eventually be in that kind of a situation. So for the vast majority of you, again, assuming you don't have a lot of protein in the urine, not to worry, okay? Okay. Oh, I don't know. That was I don't know whose computer that was, James. So one of our computers is talking to us. Okay. So why is that protein in the urine so important? Why do we keep harping on the urine protein? Give you a good example. Let's say you have an EGFR over 60 or over 70 or over 80, but you've got 2+ protein in the urine. You may be more at risk of eventually needing dialysis or transplant than somebody who's got a 30 to 45 EGFR. So the protein, who does not have protein in the urine. So that protein in the urine, it's a very simple factor. Protein in the urine has over and over and over again in research studies been shown that that is a very strong predictor of who may progress. So let's get into specifics of what's a significant amount of protein in the urine that we've been asked before. So James, give me your opinion, and then I'll tell you what the kidney docs say.
Well, I believe what is significant is a 3+, or is it a 2+ on a dip? I can't remember. Here's what I know. Mine was high in the beginning, and now it's trace or none. Okay. So I'm good, and I keep an eye on it. I get the urine test when I go in and get my labs, or they don't do it every single time now. It's like twice a year I get urine, and it's still low, so I feel good about it. Well, and one problem is there's different scales, whether you're in the U.S. or the rest of the world, and I always get those confused.
You're absolutely right, and it is very confusing. And I'll try to make it simple as I can. Trace, generally, not to worry. 1+, okay. The reason why the urine dipstick is not the best way to determine how much protein is in your urine, because what the kidney does is it can concentrate your urine. If you have not been drinking water and you've been out sweating, if your kidneys are working right, they're going to hold on to as much water as possible. That's what the kidney does. By the same token, if you flood yourself with water, which a lot of people do, going around drinking water all day, if your kidneys are normal, they are going to get rid of that water to keep yourself in balance, okay? So therefore, if you had a real concentrated urine, a 1+ will mean a different thing than if you had a really dilute urine. Does that make sense? If you had a really dilute urine, but it's 1+, that's probably a lot of protein, because that 1+ can be something like 100 milligrams of protein per liter of urine. And if you're making 10 liters of urine, that's a lot of protein. If you're making only half a liter, well, it's not that much protein. So that's not the best way to do it. The best way to do the urine protein is to do a simultaneous urine measurement of the albumin and the creatinine. And I'm going to get to that in a minute. And that's the best way. And you don't have to do 24-hour urine, which is another way to do it, which James knows is a real pain. You don't want to fill your refrigerator up with urine.
Time ago.
You don't need to do it.
Yeah.
You don't need to do that. So 1+ can mean something depending upon, your circumstances. And the albumin to creatinine ratio over 30 for this country, the units in this country, and 3 for in Europe and other countries. The reason why is this gets into the units of measure, which I'm not even going to mention because it's too confusing. So in your country, if the U.S. values would be divided by 10 to compare it to a European value or an Australian value for that matter, or UK value. Most of my fellow kidney specialists would say, if you have consistently 2+ or more, you've got real protein in the urine. 2+ or more, consistent. And just like one value is not going to make it for EGFR, one value for urine protein is not going to make it. You need to get repeated values to know what your kidneys are doing. Are they getting better or worse over months and years, not days or weeks? And that's why you need repeated values of EGFR and urine protein. And the best measure of urine protein, your doctor can do it. The doctor can get in the urine the albumin to creatinine ratio. That'll give you a good estimate of how much protein your kidneys are spilling in 24 hours. And the reason why you got to repeat it is because just like there's a lot of things that can affect your EGFR, your estimated kidney function, a lot of things can affect your urine protein, like a urinary tract infection and many other things. So you want to ask a question before I go into how to live longer, which everybody would like to hear about?
Well, here's actually a really good question. It just came through from Deb, and it's related to what you're talking about, the GFR and the age. How at an older age, a lower GFR may be not as bad. Deb says if a person's over 70 with 3A, should they be watching their potassium, phosphorus, and protein in their diet?
Okay, we're not going to focus on diet tonight. And James has some really good dietitians, I assume, still on his show.
Yep.
And I was asked the other day, and I feel a little funny about it because I'm not a dietitian. Should every person who's been diagnosed with CKD see a dietitian? The main thing to know is there's no need to restrict your diet until you get to very low levels like stage 5. And for some people, stage 4. For sure, less than 15 is stage 5. That's when you may start running into trouble with potassium. But before that, you're probably better off having a plant-based diet high in potassium because potassium is good for you. Potassium is important and good for you. So no need to restrict potassium, no need to do any dietary restriction, and no need, and I will not dwell on this all night, no need to be on a low protein diet. Absolutely no need. One of the reasons why I wrote my book is because the other major books out there were pushing a low protein diet if you've got stage 3 or stage 4 CKD. Unnecessary, dangerous, and one of the books has a companion product that they sell, which are keto analogs for very low protein diet. Dangerous, unnecessary. Rarely do I recommend it. It would only be recommended for people who are doing everything else to slow kidney function, which we've talked about in other Dadvice TV programs, and I will talk about again. If you've done all of those things and you're a young patient and your kidney function happens to be going down fast, that's the only time that I would recommend a very low protein diet with keto analogs. For the vast majority of you, 90+% of you, you don't need to do that. Plant-based diet, yes, good for your overall health, help you live longer.
I always encourage people eat a heart-healthy diet. Try to be
Absolutely.
a heart-healthy lifestyle.
Absolutely.
Because one thing you talk often about, and I don't think it's mentioned enough, is kidney disease is a risk factor for heart disease. That's how we need to look at it. So if my GFR was in the 50s and I knew all the stuff I knew now, I'd be like, okay, I'm eating a heart-healthy diet. I'm going to be exercising, cut anything that's bad for my heart so that, I could be as healthy as possible.
James, you did a very nice transition for me. Thank you.
So
when we talk about
I don't see the notes, everybody.
when we talk about living longer, what James just said, the most important thing for you folks with stage 3 is to know what James just told you. It is a risk factor for atherosclerotic cardiovascular disease.
I'm glad you didn't try to make me say it.
I'm going to break it down. It's a risk factor for getting heart failure, for getting heart attacks, for getting strokes, for getting what they call mini strokes or TIAs, for getting chest pain or angina, for having to get a bypass operation, to have for heart arteries, to have to get a bypass operation because your legs are not getting enough blood to them. That's called claudication. When you have angina of your legs, it's called claudication, not getting enough blood to your muscles. Those are the atherosclerotic cardiovascular disease, the number one killers of most folks around the world. And when you happen to have a abnormal EGFR, and especially when you also have a good bit of protein in the urine, you are at risk, of higher risk of getting atherosclerotic cardiovascular disease. And the healthy behaviors, which we're going to mention a couple of them tonight, are really important. And the lower your EGFR, the more benefit that these healthy behaviors will have. Because the lower your EGFR and the higher your urine protein, the more likely that you're going to get into a problem with one of the things I just mentioned, those things that are part of atherosclerotic cardiovascular disease. And the worse off your kidneys, the more that taking on these lifestyle things are going to increase your lifespan. What's my number one go-to lifestyle change that I'm going to focus on a bit tonight, James?
Your number one lifestyle? Well, if you're a smoker, stop smoking.
Well, that's right. Right. Okay. You're right. That
That's
is number one. Thank you. I won't argue with that. I'm going to get to that secondly, but you're absolutely right, James.
Number two, keep moving, exercise.
Yes. Okay. James, you're right on it. You're on it tonight. I love it. Okay. All right. Exercise. I think I call exercise the fountain of youth. This is one of the biggest pluses to longevity, things you can do to live longer. Some people say that not exercising and sitting more than 8 hours a day, which is the way the vast majority of us live, more than 8 hours a day. Some people say, and I'm not going to dwell on this, that this may be as bad as smoking, which we're going to get into in a minute, James. Or being massively obese. If you don't exercise, it creates a big risk. And under COVID, we've been sitting on average of 15 to 20 hours a day. And if you are one of these folks that has a desk job, try to take breaks, try to get up and move around, because it's not only good for your longevity, but it's also good for your aches and pains, especially in your back and down your legs. Get up and walk around.
Okay, that's my biggest challenge. I work remote. I sit here in this chair. I got a very comfortable chair, a cushion under it that's extra comfortable. And like today, I had back-to-back meetings. I didn't even take a lunch break. I had meetings through that. And I looked at my watch, and there was 4 hours where I did not stand up. And it's like, oh, that's so bad. And I do it quite often. I know a lot of people. It's a challenge to remember to get up.
Get up and move around if you can. Get up and move around if you can, because it will help create a better back structure, less pain from sciatica and so forth. All right, so how much do you need to exercise? Any exercise helps. Any exercise will help. And it's a little bit of a dose response, but you don't have to go crazy. Because I guess if you really, well, we won't get into it. I'm sure we'll get a question from somebody who does marathons or triathlons. But any exercise is good. It's a dose response. The more, the better. And try to start with slow walking. Nothing special. Walking around the neighborhood. Walking in the mall. Gradually increase your pace of your walking. If you happen to have a stationary bike, you want to watch TV, get on your stationary bike while you watch TV. If you're lucky enough to have your own treadmill, get on your treadmill. If you're lucky enough to join a gym, do it on the gym. The gym has all kinds of ellipticals and treadmills and bicycles. Get on it. And you don't have to push yourself. Just try to get on it so that you can actually talk to someone next to you and be slightly short of breath. You don't have to be, I can't talk. You don't have to push yourself that hard.
I'll tell you, Doc,
Yeah.
One thing I do to, when I can to get extra steps in, and it makes it so easy, when I go shopping, especially if it's with my wife, because she takes a long time, I walk every aisle just looking, and I don't even notice it. And I could easily get like a mile and a half, 2 miles in a Walmart just walking all the aisles and looking. And I was occupied, it's air conditioned, and don't even notice it.
And some of you may have a Fitbit, and I think that you will be surprised at the amount of steps you're taking if you just make it a practice to get out and move as much as you can. Gardening is fine. Playing with your kids is fine. Dancing is fine. All going on a bicycle ride. All of these things. You should set a goal for around 30 minutes, 5 days a week. That's 150 minutes a week. Set your goal for that, okay? And you don't have to do that right away, but try to get there. Try to get there at least 30 minutes, 5 days a week. Now here's the thing. You are not going to believe all the benefits, and these are real benefits. These are science-based benefits. The research is really strong about these benefits. It will lower your blood pressure. It will lower your blood sugar. And actually, some people with exercise and diet can cure diabetes, for sure. That's been shown. It will lower your bad cholesterol. It will lower your weight. It will lower your stress level. It actually decreases a cancer risk, which is mind-boggling. It slows the loss of your brain cells, which I am very tuned into because I have dementia very strongly in my family. And the one thing I think that we can do as we get older is continue to exercise to keep those brain cells functioning as good as we can. And in my opinion, it is better for dementia than any of the drugs out there which have not been shown to work, or supplements. It can improve your memory. As we get older, we will all lose body muscle. As long as you exercise and work, like what I do, I go to the gym. I started going to the gym a few decades ago because I knew that my muscles were going to disappear. So I try to build muscle. It helps your breathing. You sleep better. You get a better sex life. I mean, it will.
You should lead with that one.
As we get older, it will keep you independent longer. It will decrease depression. It will decrease your anxiety. And you will have less aches and pains in your joints. And if that is not a reason to exercise, all these reasons, I don't know what is. But to me, that is the number one lifestyle change that I hope all of you viewers will at least consider. And as James said, the number one cause of preventable deaths is smoking. It accounts for about 1 out of 3 preventable deaths from heart disease. And this will include secondhand smoke. Just because you're not smoking, if you're in a closed room or your kids are in a closed room with smoke, that smoke can contribute to them getting heart problems, heart attacks, and strokes. So smoking is really bad. It's the one thing that you can do if you're smoking to decrease your risk of death and your family's risk of death.
Now, a related question, Doc. If someone was a smoker and they stop, is whatever damage they did done, or are there benefits to stopping sooner?
Absolutely. The benefits are there. And my wife was a smoker and she quit smoking. And I think it's something, and I have to look up the data, but something like 10 years or 15 years, you're back to being a non-smoker in terms of your risk level. So you get off those cigarettes, you can get yourself back to a much lower risk of dying from compared to people who continue to smoke. And we're talking about kidneys tonight. You stop smoking, you can slow the decline of your kidney function, and you certainly can decrease your risk of heart attacks, strokes, TIAs, myocardial infarctions, and all that stuff. Less coughing, less shortness of breath, better smelling breath, whiter teeth, healthier kids, not getting as much secondhand smoke. And there are so many organizations that are promoting stopping smoking. And I know the UK has a massive program to get the whole population off cigarettes because it is the number one cause of preventable deaths. And you want to not just do something for your people, you want to save money for your national health care for health costs. That's a biggie. So they're trying all kinds of things to get people off cigarettes.
You want to save money and you want to keep them paying taxes by being alive.
Yeah. Yeah, that's true too. In the U.S., the American Heart Association, the American Cancer Society, they all have lots of information on ways to get off the cigarettes. You can use nicotine patches. You can use nicotine gum. You can use nicotine tablets. Better than smoking cigarettes. You can also do e-cigarettes, which is controversial, but it probably is less harmful. But don't forget, it's still got the nicotine, which is addictive. Stay away from any of those flavored e-cigarettes, because those flavored e-cigarettes have particles in them that can get into your lungs and cause real damage beyond what just smoke does. Try to keep your kids off the e-cigarettes. It's trendy. They all do it. Some, not all. A lot of the kids do it. It has got lots of nicotine in them, and they can be addicted at an early age. Try to keep your kids away from the e-cigarettes. And chew is not a lot better. Chewing tobacco can give you cancer of the mouth. It may be better in terms of lung problems, but it's not without its risk. It can give you cancer. And so the other, let me see here. Okay. All right.
And your pages are right on top of your microphone.
I'm sorry. Sorry, folks. Yeah, I mean, chew can, you lose your teeth, you mess your gums up, and you can get cancer. We're not going to spend a lot of time on the other lifestyle issues, but I will mention them real quickly. As we mentioned earlier, plant-based diet, very, very, very beneficial. You're not only going to do something to help you live longer, potentially slow your decline of kidney function because it's lower in protein. I am an advocate of not eating a high protein diet because that can cause your kidneys to fail quicker. You don't have to be on a very low protein diet, but you can be on a relatively low protein diet, because in the United States and most of Europe and most of the developed world, we are taking in over 100 grams of protein, and we should be shooting for more like 60 grams of protein a day. And a plant-based diet will go a long way to doing that. And you're going to help the climate disaster worldwide, because meat comes from cows, and they produce the most harmful carbon product called methane.
Yep.
When they burp and so forth, which is kind of sounds funny, but methane is a much bigger factor in climate than is the carbon from our airplane burning fossil fuels. So yeah, so you're going to do something for your family, for yourself, and we're not going to also discuss gold blood pressure. You certainly want to get the gold blood pressure, and you want to get your gold LDL. Gold blood pressure in general is 120 to 130 on the top number, and LDL lower than 100, and for diabetics, certainly I would say even lower than 70 to get your bad cholesterol down to that level. And I guess we have time for questions. And
we got a lot of time tonight.
Okay, well, I'm going to just answer the question from last show about the causes of kidney disease. So, James, what would you guess would be the top listed causes of kidney failure around the world?
Number one, diabetes. Number two, uncontrolled blood pressure, which is really, really high. And I don't know what number three is.
Okay.
I can't
So,
remember.
okay, so you're right. So diabetes is listed as the commonest cause of so-called end-stage kidney failure to the point where you need dialysis or a kidney transplant. High blood pressure is listed as the second commonest contributor to kidney failure. Knowing full well that most people, we don't have a definite diagnosis because we don't biopsy your kidneys. It's made as a clinical diagnosis. The third most common, James, is so-called glomerular disease. And I direct you to my book where I talk about the parts of the kidney. Remember we talked about glomerular filtration rate? Well, that's the glomerulus. That's the business end of the kidney. It's lots of tiny little blood vessels that filter the blood out. So there's lots of different glomerular diseases. As it turns out, diabetes is probably the commonest cause of glomerular disease, but it's separated out from the other glomerular diseases. The glomerular diseases that people may know about or have heard about are things like systemic lupus, and then there's lots of glomerular diseases that are defined by a kidney biopsy, which I'm not going to get into all the names. There's a long list of them. The other cause of kidney failure, which just accounts for a small percentage of people with end-stage kidney disease, is polycystic kidney disease. That's a genetic disease that is a dominant trait passed on. If you have it, you have polycystic kidney disease, 50-50 chance that one of your kids will also get polycystic kidney disease. Okay? And the last type of kidney disease, oh, by the way, the other things that cause glomerular disease, which people certainly have heard of, would be something like HIV, something like hepatitis B, or hepatitis C. They all can cause types of glomerular disease. The last type of kidney disease, and one other type of glomerular disease that used to be common when we didn't have antibiotics, is strep. People would get strep throats, and they would get a glomerular disease after a strep throat. Yeah. And that's one of the reasons why your doctor may recommend that if your kid has strep, that the rest of the family should be taking antibiotics to prevent the secondary complication of strep throat, which can be a glomerular disease. These are pretty rare these days. They account for a very small number of people that wind up going on dialysis. The other general type of kidney disease, you may have heard of pyelonephritis, like kidney infection. I don't know if you've heard of that term. It's also called, so the two major parts of the kidney are the glomeruli, lots of blood vessels, and then the rest of the tissue of the kidney is called the interstitial area. And so if you get chronic infections of the kidney, they can cause, or you're taking lots of drugs that can do this, like Motrin and Naproxen, the NSAIDs, they can cause interstitial kidney disease. The other kind of common thing, used to be a very common, it's still relatively common, is intravenous drug use, illegal, especially illegal intravenous drug use, is another cause of glomerular disease. That's kind of a quick overview of some of the causes of kidney disease. And we could take some questions.
Sure. I have a couple that came in here that are great questions. Philip asked, when would you recommend a person get a kidney biopsy?
That is a really complicated and good question. In general, we go back to the protein in the urine story. If you've got a lot of protein in the urine, and I'm talking about 1,000 milligrams or a gram of protein, or 2 grams or 3 grams, if you've got that level of protein in the urine, there's a term for that. It's called nephrotic syndrome. I don't know if any of your viewers have been told they have nephrotic syndrome. That means they have a high level of protein in the urine. And there's numerous causes of high levels of protein in the urine causing the glomerular diseases that I mentioned. And the only way to know which one you have would be a kidney biopsy. And it's not just a biopsy for the heck of it, but a lot of these unusual diagnoses, the various types of glomerular diseases, may have certain treatments that have been shown to be beneficial. The most common type of glomerular disease that gives you heavy protein in the urine is called membranous glomerular disease. That's the most common.
Very good. Alicia asks, can CKD patients take antibiotics, or do they need to worry about it lowering their kidney function?
In general, you don't have to worry about it, but doses of antibiotics need to be adjusted for some of them. And the commonest antibiotic that people might be taking would be the sulfa drugs like Bactrim, Septra. A lot of people are taking those for infections in the urine or other things, and those have to be adjusted depending upon your level of kidney function. There is another class of heavy-duty drugs called aminoglycosides that if you happen to get seriously sick, you may need to take those. And again, those can be life-saving, but they can be potentially harmful for the kidneys. Most antibiotics, you don't have to worry, but some you do. Yeah.
Yeah, and my doctor, when I first was diagnosed, they told me whenever you get a prescription, if you worry, just ask the pharmacist, is this a renal dose? And they know some of them need to be adjusted, and then we can work through that. Maria asks, and this, I don't think I've ever seen this question before. This is a really good one. Should someone with CKD have any concerns about getting a tattoo?
I don't know for sure. I think not. I think not. You're not injecting it into your bloodstream. If you inject anything into your bloodstream, the kidneys as a filter may not like what you're injecting. Street drugs for sure, the heroin, the stuff that people may shoot up, that can cause kidney damage. But when you're getting a tattoo, it's not in the blood vessels. So I don't know for sure, but my opinion is probably not.
And I'll tell you, my daughter wants her ears pierced, and I went and I looked at the ear piercings at the regular mall stores, and then I went to a tattoo/piercing store. So much cleaner and better at the tattoo stores with the prep and how they do it. So that's probably where we're going to get hers done once she has her nerves ready for it.
Okay, cool. Yeah.
All right. So are there any questions you see? Because we just have about 10 minutes left. We
Okay.
got a
Well,
lot of questions and comments in there. We broke 100 earlier. I saw the count go by.
uh, okay. Uh, my blood pressure due to my CHF is the main factor of my CKD. Okay. Well, we didn't talk about heart failure, but heart failure is, and that's not even listed actually, James, as a cause of end-stage kidney disease. Isn't that interesting? It's not listed as one of the commonest causes. But I think that especially as we get older, as our pump gets weaker, it will affect your kidneys. So you may have underlying kidney problems for one reason or another. And if you have a weak pump, it can make your kidney function worse. And Maria said that her blood pressure can certainly cause heart failure and it can also cause CKD. Patricia has stage 3 of polycystic kidney disease, and there is a drug that Patricia, that you might ask your doctor about to slow progression of polycystic kidney disease. And my opinion about this drug is the same as my opinion about a lot of things that people may want to do to slow the decline, whether it's aggressive lowering of protein, in your diet, aggressive lowering of blood pressure. If you have a polycystic kidney situation where your kidney function is going down rapidly, I would definitely recommend the new drug. Somebody, again, so Jose is talking about diet, fasting, vegetables, and just having water. GFR went up to 63 from 51. Again, I frankly, Jose, that I don't know that that's necessarily a real change. And the other thing I would say is that if you're drinking lots and lots of fluids, you can dilute that number so that when you dilute the number, your EGFR may appear to be better, but it may have to do with just having a lot more fluids in your body. And the thing about eating vegetables and not protein, it's also known that if you're eating a lot of protein, you're going to wind up having potentially higher creatinine, which is the determinant of EGFR. So it may have nothing to do with the fasting or the vegetables you ate. And the 4 months, I don't know that I could say that that's really something I would recommend. I say long term, again, if you've got stage 3, you want to long term do healthy diet and healthy activities like physical activity.
And Doc, when you talk about diluting, just to make sure everyone understands, how much of a difference would a person need to make for 5 or 6 points on their GFR with their creatinine?
Well, first of all, 5 or 6 points is lab error. And so, comparing somebody one day to the next, there's lots of variation that could be due to factors that we're not even going to know. The lab error, the state of hydration, your diet. So that's why you need multiple values to know what's going on.
And that creatinine number is so small that just a slight dilution of it can make that difference. It's a tiny number.
You hit that on the head, yeah, because a normal creatinine is theoretically around 1. So it could be 0.8 to 1.2. And if you go from 1.2 to 1, it could be a massive change in EGFR, just by that little change in creatinine. So the foaminess,
that's
a lot of
always
people
here.
Everybody, yeah. Foaminess doesn't mean anything. Urine test is the thing that will determine protein, not foaminess of the urine. I wouldn't worry about that at all.
You won't believe how many pictures I get of foamy urine. People say, is this kidney disease?
Yeah. And again, creatinine 1.2, 61. Again, so that some labs may not even report a 61 because like James was saying, today your creatinine may be 1.2, tomorrow 1.3, the next day 1.1, the next day 1. And your EGFR can vary from 50 to 70. So that's why those upper level EGFRs are just not something to be concerned about. Somebody starting a beta blocker. Yeah, in terms of treating Maria blood pressure, if your blood pressure is, Maria, all patients who are being treated for blood pressure problems, I recommend a water pill as part of the treatment. You're on metoprolol and amlodipine. Ask your doctor about getting a water pill. And many people with significant blood pressure, hers is 170 over 90 roughly.
Yeah.
You may need at least 3 or 4 drugs.
That's similar to how mine was, and I have a whole selection, and one of them is a water pill. And now mine's controlled. It stays 120s, just below 120, over usually high 80s, mid 80s.
Right. Sodium bicarbonate. Sodium bicarbonate is being studied as one of the things to hopefully slow progression of kidney decline. And it has not been proven yet. But I recommend it for those of you on your lab value. If your CO2 on your lab value is below, the normal is around 25. If it's below 22 or 20, I recommend sodium bicarbonate, which can potentially be beneficial. It will not be something for everybody. Yeah, Australia, I think you are in the millimoles, so it would be a value above 3 milligrams per millimole would be considered abnormal. In the States, it would be 30 milligrams per gram of creatinine. Protein in my urine.
Here, someone asked, what are the best kinds of drugs to lower protein in your urine?
Well, next show, I mentioned to James, I'm going to talk about the game changer drugs that were originally designed for diabetics but are being used in non-diabetics to help you live longer and slow decline of kidney function. The two types of drugs that are available for all of you, and you definitely should be on them, especially if you have protein in the urine of any significant amount, are the ACEs, the drugs that end in pril, like captopril and allopril, and the ARBs, the drugs that end in tan, like losartan. So those are the ones for sure that could help anyone to slow decline of kidney function if they have significant protein in the urine. Yes, okay, so I don't want to repeat some of the questions that you said. Yeah, so what is 2 plus? Okay, 2 plus, okay. Again, urine protein 1 plus is around 100 milligrams per 100 mLs, which would be around a gram per liter. And trace is around 30 milligrams per 100 mLs, or 300 per liter. Actually, that's not right. 30 milligrams.
It's always confusing.
Yeah, okay. It's 1 plus is, trace is 30, 1 plus is 100 milligrams per 100 ml. Yeah. But, and 2 plus would be 200 milligrams, 3 plus would be 300 milligrams. So if you had 3 plus, 300 milligrams per 100 ml, that would be nephrotic range proteinuria. That's heavy proteinuria. 2 plus is 200. And again, we don't know how much urine you're putting out in a day. You may put out 500, you may put out a liter, you may put out more. But so the dipstick will give you that value when it shows you 1 plus or 2 plus. It'll tell you the units next to it. But just to make it simple, trace is probably not important. 2 plus consistently would certainly be important.
All right, Doc, we're at the top of the hour.
Okay.
Do you want to get one more question in? I'll let you get one more.
Okay.
Let's see who's the lucky viewer out there.
Philip is talking about IgA. IgA, there are some new treatments for IgA. It's one of the glomerular diseases. A lot of people with IgA do not have a lot of protein in the urine. If you are one of the IgAs, glomerular disease, with high protein in the urine, you're probably a candidate for some of the newer drugs that are being used for IgA. And I guess that's and somebody has pain, it's not from your kidney. If you're mopping, you had pain in your back. Kidneys do not cause pain. Kidney problems are painless. You will not have symptoms even when you have end-stage severe kidney failure. unless you've got polycystic kidney disease where the kidneys can be large and painful. That's the only situation.
All right, Doc. Thank you so much. I'm going to mention your book one more time. So if you're new here and you haven't read Dr. Rowe's book, I encourage everyone out there. As you saw, he's great with facts, great with explaining things, making things sound simple and focusing on what we really need to know and helping us get rid of all that extra worry that comes with being diagnosed with kidney disease. His book is called Learn the Facts About Kidney Disease. You can get it at pretty much any bookstore. They can order it for you, or you can go to that link right there on the screen, go.dadvicetv.com/book, which will just take you to this book on Amazon where you can get your own copy of it. It's a very, very easy read. My version, I'm still unpacking from my moves. I'm still middle move right now. It is the bind, the back, what do you call it? The spine of the book is so worn down from folding over, folding pages, marking things. So much great information in there. So anyone out there who's worried about kidney disease, definitely a great book to get hold of. All right, that is the end of our show for tonight. We will be back together in about 3 weeks or so. I'll post the schedule on dadvicetv.com. And I want to thank everyone else out there for being here. It's been great, and I'll see you all in the next video. Bye, everyone.